Thank you, Janita. And I think Kunal has taken the exhaustive talk on how we can actually target each and every lesion that we can actually see on the scan. Just for the endobronchial ultrasound, uh, we know that there are indications. The indications are mostly curative, that once the patient we deemed fit, that it can undergo curative intent of treatment, maybe surgery or maybe some aspect of the CTRT, then we will try to stage the mediastinum. And we can see that there are a lot of nodes that are there into the mediastinum, and they may and may not be seen on the CT, they may and may not be PET avid, and there are a lot of other issues that are associated with these mediastinal lymph nodes. So there are various vendors are available that actually can have their own different kind of techniques, and one needs to adjust these kind of vendors and try to adjust and then initiate the endobronchial assisted ultrasound. So when we talk about imaging versus sampling, it purely means that imaging doesn't have that kind of correlation when we try to talk in terms of the sampling. So sampling almost variably the sensitivities reach around 100%, and the negative predictive value will reach around 100% in the various studies that we are talking about. But that kind of thing is not there into the imaging, and that is the reason actually we have to screen the mediastinum with the endobronchial ultrasound before going for any kind of curative treatment, because most of the times we are picking up contralateral mediastinum, then they are deemed unfit for the surgery. So when we talk about the sensitivity into the various randomized trials, actually it is having quite good sensitivity in terms of that. And when we talk about it is relatively less expensive in case of mediastinoscopy. It almost is having equal amount of sensitivity and equal amount of negative predictive value when we talk about the mediastinoscopy. So as Sir has discussed about that, there could be possibility that there is a PET avidity, and these might just turn out to be tuberculosis. And there might not be any avidity, and these might turn out to be the cancerous lesions. And in countries like India, these failure rates can be around 10 to 15%. So this is how typically we will go, that there is a bronchoscope there in which there is an ultrasound probe. And in the guidance of the ultrasound probe, there is a sheath that is coming first, and then followed by the needle that will come. And that needle, then it will go into the node, and through this we can actually visualize that this node has been targeted. So this is how, once it is reaches into the tracheobronchial tree and the nodes that are surrounding, we cannot see these nodes by the bronchoscopy. But the moment actually we will abut our ultrasound probe in that area, we will see all these nodes, and then we will stage which nodes needs to be sampled. And something which is more than 5 millimeter, we will try to target and do 3 samples at a time, just to be sure that the node is not having any kind of metastatic infiltration. So just coming about the various scenarios that one can come across. In this particular case, it is an indeterminate node on the PET CT, but it proven to be malignant on the EBUS TVNA. So it was a scant metastatic adenocarcinoma. Though the nodes are very small, they are not having any significant avidity. Still, they are positive on the EBUS, and that is the reason actually that we will go ahead and prove that these are going to be the positive nodes, and that actually will change the type of therapy actually we are giving to the patients. Again, in this particular patient, that again we are not seeing any uptake, and the EBUS TVN is also showing a reactive node, and we are not very sure. It looks like that these nodes could be similar on the CT scan, and there is a faint uptake on these nodes, and we don't know whether it is again going to be reactive or it is going to be metastatic. And the EBUS TVN shows that there is no evidence of malignancies there. So this is another scenario. Coming to the scenario where we may think that it is going to be reactive, because we will see that there is going to be the fatty hilum in these small nodes, and these are looking to be reactive, but again we are not very sure, and when we target these nodes, it turned out to be an reactive nodes in that scenario. Coming to this interesting case, sometimes when we have adenocarcinoma which are maybe having mucinous differentiation, in those cancers, there might be chance that the nodes might be negative. So in this case, we are not seeing any uptake in these areas, but again, all the nodes that are there into the mediastinum, they are showing the foci of metastasis. So it will change significantly the way actually we are actually planning our treatments. So just to conclude, EBUS is something which is a diagnostic tool which is having a very good sensitivity and specificity for detecting metastatic mediastinal adenopathy, and again at the same time it will tell whether the nodes that are we are seeing enlarged or having FDG avidity may be having a positive aspect of granulomatous disease or something else. So potentially many patients which might deemed unfit for the surgery because there is a PET avidity nodes, they might become fit for the surgery because now the nodes are actually coming as a granulomatous nodes. So this is something which will conclusively change the scenarios from maybe from the curative through non-curative aspects or non-curative to curative aspects. On either ways it will works, and it is also very safe and minimally invasive techniques. And now it is accepted as a standard of care when we are actually having doubt in which there could be a suspicious nodal disease that will. So it will help you in targeting the multi-station N2 or N3 disease. We start with N3, we will go with N2, and then we will come in the N1 region. So it will act as a filter before the surgery to actually stage the mediastinum in a better way. So thank you so much. If there are any questions, we would like to take. Yes, please. This one? The case scenario first. Yeah. First case scenario 1 है यही है. No. What you are asking actually I couldn't get it.
So in the case scenario 1 there were two nodes which
Yeah,
so
this one and this one.
Yeah, so that the right side node seems little far from the trachea. So my question is, how deep can be, I mean it is 5 mm, 10 mm, 15 mm, can we access through this EBUS?
Yeah, so your question is very good, that how far we can actually go. So once the probe is attached, so it can go up to the 5 centimeter. So the 5 centimeter depth that is there from the sheath. So if we see the sheath, so this is the sheath that is there, and this is the ultrasound probe. So we will see the ultrasound probe, and this needle that is coming, it will have a 5 centimeter depth. So it can go into the area from the tracheal margin around the 5 centimeter of the viscera that it can be targeted. But these nodes are going to be difficult. Those which are nearer, they are easy to be targetable. So that's how. So it will require a little bit expertise. With the help of the thoracic surgeons and the pulmonologist, we are able to target these nodes, because one need to be very good in the bronchoscopy, evaluation of these nodes, knowing the stations, anatomical details, and how actually we can safely target these nodes.
And what would be the majority of the cases we usually pick these nodes, like 1.5 centimeter in routine clinical practice?
So we will do EBUS in each and every case in which we are actually planning for an surgery. So every case we will go for an EBUS first, and we will start with the N3 first. We will rule out whether the N3 is positive or not. If the N3 comes positive, we will stop the procedure, because now our targeted is the contralateral mediastinum is involved. Surgery is not feasible. And whether they can go ahead with the CTRT that we have already discussed in our MDJC. If that is not also feasible, then these patients will go for a palliative chemotherapy, depending upon what it has turned out. If it is having mutation positive, it might go for target, or it is having PDL1 something, might go for immunotherapy. But the moment we will start first to rule out with the N3, if the N3 comes positive, we will stop the procedure. Then subsequently we move to N2 and the ipsilateral mediastinum, and then we will try whether these nodes are bulky, multi-station. If it is multi-station, again that helps the surgeons whether actually we are talking about the multi-station metastatic nodes, what they want to actually really do. They want to give a neoadjuvant chemotherapy first, and then followed by they want to do the surgery or something like this. So ruling out N3, then N2, and then N1 if required. Anything else? So whatever nodes we are seeing it, we sample each and every node, which is more than 5 millimeter. Yes, and that with the 3 passes. And we have the rapid on-site team with us. So when we actually sampling these nodes, there is one resident that is sitting from the pathology sites. They will tell us whether the node is adequate or non-adequate. If they are having any doubt, they will send these slides to their consultant, and then they will confirm whether this node is positive or not, because it will make a lot of difference, because you cannot give anesthesia multiple times. The procedure cost is high, the OT cost is there, and so many things are actually there. So Uh, we do employ the rapid on-site examination and evaluation at our own setup to triage whether these nodes are adequate or non-adequate during the sampling. Anything else? Can you take the mic actually? I can. Hello? Endoscopic ultrasound, what is the question? So, can somebody tell me what is the question? Yeah. So, EBUS is, that is having a different probe that we are actually doing. It is not like a routine EUS probe that we are actually taking it, but the EBUS probe can be done as an EUS. So the vice versa is, I think, not possible. Actually, I think Virendra is there. If Virendra is here, he can tell more about it. But endoscopic ultrasound alone, we will stage and map with the ultrasound first and match whatever we are seeing on the PET CT and the CT. And we need to know that these are the 7 or 8 stations that we have to target, and then we actually start with the sample. So we will do the mapping first with the endoscopic ultrasound, then we will start the sampling procedure. So we document what is the size, what is the necrosis, whether the margins are correct or not, and then actually we will do the sampling. So in case, maybe sometimes what happens in rapid on-site, they will say it is reactive, but the final comes that it is going to be an involved. So that is happen because when they gather all the information during the finalization of the report. Anything else?
Can I just comment on that? What he asked, I think what he was asking was basically when can you use an endoscopic ultrasound as in gastroenterology for combined sampling or combined staging. And I think if it's a level 8 and level 9 lymph node, very often you will not get it by the EBUS.
So those, so paraesophageal nodes and something like this, you can use the same scope, go into the esophagus and actually can do EUS and actually can sample these nodes.
So it's just modifying the technique.
Yes, nothing else.